In this episode of USMLE Step 2 CK Rapid Review, let's talk about congenital heart diseases. This is one of those classic Step 2 CK topics that always shows up, and the key to mastering it is to understand the clinical patterns rather than memorizing every defect. Imagine this scenario. You're in the newborn nursery, and a baby looks kind of blue. What do you do first? You want to figure out if it's central or peripheral cyanosis. Central cyanosis means there's low oxygen saturation in the blood going to the whole body. You'll see it in the lips, the tongue, and the mucous membranes, not just in the hands and feet. The problem here is that oxygen isn't reaching the bloodstream properly, which can happen in pulmonary disease or in a cyanotic congenital heart defect. Peripheral cyanosis, on the other hand, happens when blood flow is sluggish or when the tissues are extracting more oxygen than usual. The fingers, toes, or around the mouth might look blue, but oxygen saturation is normal and the mucous membranes are pink. This can happen with cold exposure, vasomotor instability, or low cardiac output. Here's a quick tip for the exam. If a baby has cool extremities and normal oxygen saturation, it's peripheral cyanosis, which is benign. If the baby has warm extremities, blue lips or tongue, and low oxygen saturation, that's central cyanosis, and that's concerning. Next, you'll want to give 100% oxygen. This is part of what's called the hyperoxia test. If the baby's oxygen saturation goes up significantly, usually by 10% or more, that means the lungs are the problem, something like meconium aspiration or pneumonia. But if the saturation doesn't improve, or the baby gets unstable, then it's most likely a cardiac cause. In that case, you don't wait around. You start Prostaglandin E1 to keep the ductus arteriosus open while you figure out exactly what defect you're dealing with. That step can literally save the baby's life. Now let's go over the major congenital heart diseases, starting with the left to right shunts. These are acyanotic defects that can cause heart failure later. The big three are atrial septal defect, ventricular septal defect, and complete atrioventricular septal defect. Complete atrioventricular septal defect, or CAVSD, is classic in babies with Down syndrome. It happens when the endocardial cushions fail to fuse, so you end up with both an atrial and a ventricular septal defect, plus a single common AV valve. Around 6 weeks of age, when pulmonary vascular resistance naturally drops, these babies develop heart failure. You'll see poor feeding, sweating with feeds, and crackles from pulmonary congestion. On auscultation, you might hear a fixed split S2 from the ASD, a systolic ejection murmur from increased flow across the pulmonary valve, and maybe a holosystolic murmur from the VSD or from AV valve regurgitation. Here's a test tip. If you have a baby with Down syndrome who develops heart failure around 6 weeks, and you hear a fixed split S2, think complete AV canal defect. Now, an atrial septal defect, or ASD, is most often due to a secundum defect. Most patients are asymptomatic until adulthood. You'll hear a wide and fixed split S2 and a mid-systolic murmur due to increased flow across the pulmonic valve. Over time, that extra blood flow to the right side can cause right atrial and right ventricular dilation, atrial arrhythmias, and even pulmonary hypertension. If the ASD is from a septum primum defect, it can be associated with Down syndrome and might involve the AV valves too. Next, the most common congenital heart defect overall, the ventricular septal defect, or VSD. This classically gives you a holosystolic murmur at the left lower sternal border. Small VSDs are actually loud because of high-velocity turbulent flow, but they're hemodynamically insignificant. Large VSDs cause symptoms when pulmonary vascular resistance drops. The left heart gets volume overloaded, the baby can't keep up, and you'll see poor feeding, tachypnea, and poor growth. Small defects often close on their own by age 2, but moderate or large ones might need diuretics for symptom control and surgery if they don't improve. The danger of untreated large VSDs is that the constant left to right shunt causes pulmonary vascular remodeling, leading to pulmonary hypertension and eventually reversal of the shunt. That's Eisenmenger syndrome. Here's another exam pearl. If the murmur of a VSD suddenly disappears and the patient develops cyanosis, that's Eisenmenger. The shunt has reverse direction. Now let's move on to conditions that depend on the ductus arteriosus for survival. These are called duct-dependent lesions. Persistent pulmonary hypertension of the newborn, or PPHN, happens when the baby's pulmonary vascular resistance stays high after birth. Normally, pulmonary resistance falls rapidly so blood can flow through the lungs. But in PPHN, there's persistent high resistance and right-to-left shunting through the ductus arteriosus. You'll see respiratory distress, cyanosis, and a difference between preductal and postductal oxygen saturations. The right hand is higher than the right foot. Causes include meconium aspiration, neonatal pneumonia, or lung hypoplasia from a diaphragmatic hernia. The mainstay of treatment is oxygen and ventilation and inhaled nitric oxide, which relaxes pulmonary vessels and lowers resistance. Next, the patent ductus arteriosus, or PDA. This gives a continuous, machine-like murmur, best heard at the left infraclavicular area. Small PDAs are often asymptomatic, but larger ones can cause respiratory distress, poor feeding, and signs of heart failure from excessive left-to-right flow. Now, in some babies, the PDA isn't the problem, it's actually keeping them alive. These are the so-called PDA-dependent congenital heart diseases. This group includes coarctation of the aorta, transposition of the Great Arteries, hypoplastic left heart syndrome, total anomalous pulmonary venous return, and tricuspid atresia. These babies might look fine at birth, but as the ductus arteriosus begins to close in the first day or two, they suddenly crash, with hypotension, cyanosis, and hypoxia that doesn't improve with oxygen. The fix here is immediate prostaglandin E1 infusion to reopen the ductus and restore circulation. Don't wait for an echo to confirm it. Now, probably the most famous cyanotic heart defect, Tetralogy of Fallot. There are 4 features: a ventricular septal defect, an overriding aorta, right ventricular outflow tract obstruction from pulmonary stenosis, and right ventricular hypertrophy. Symptoms depend on how severe the right ventricular outflow obstruction is. If it's severe, babies present early with central cyanosis. If it's moderate, you might not see much until later childhood, when they start having sudden tet spells, those episodes of deep blue skin after crying or exertion, due to a spike in right-to-left shunting. During an episode, putting the child in a knee-to-chest position increases systemic vascular resistance, which pushes more blood toward the lungs. Giving oxygen also helps by dilating pulmonary vessels. That's the physiology behind the classic squatting position that relieves cyanosis. On auscultation, you'll hear a harsh, crescendo-decrescendo systolic murmur at the left upper sternal border due to pulmonary stenosis, and often a single S2 because the pulmonary component is soft or absent. Here's an exam giveaway. If a child squats to relieve cyanosis, or if oxygen doesn't help, it's Tetralogy of Fallot. Next up, transposition of the Great Arteries, or TGA. Here, the aorta comes off the right ventricle and the pulmonary artery comes off the left ventricle. So you basically have 2 separate circulations, one oxygenated, one deoxygenated, running in parallel. Giving oxygen doesn't help because the oxygenated blood just goes back to the lungs. These babies are dependent on a mixing shunt, a PDA, VSD, ASD, or patent foramen ovale, to get any oxygenated blood into systemic circulation. They're usually present within the first 24 hours of life with profound cyanosis and tachypnea. You'll often hear a single S2, and the chest X-ray shows a narrow mediastinum, the classic egg on a string. Definitive diagnosis is made by echocardiogram, and initial management is prostaglandin E1 to keep the ductus open. Coarctation of the aorta is next. This is a narrowing of the descending aorta just after the left subclavian artery. Proximally, there's high pressure, distally low pressure. It's associated with Turner syndrome and bicuspid aortic valve. Newborns with severe narrowing can go into heart failure or shock after the ductus closes. Older children and adults might present with hypertension in the upper body, weak femoral pulses, or claudication in the legs. The classic finding is a brachial femoral pulse delay and a blood pressure difference between the arms and legs. On chest X-ray, you might see rib notching from collateral vessels and a 3 sign along the aortic contour. In newborns, again, prostaglandin E1 keeps the duct open to maintain perfusion. Definitive treatment is balloon angioplasty or surgical repair. There's also partial anomalous pulmonary venous return, where some, but not all, pulmonary veins drain into the right atrium instead of the left. This causes a left-to-right shunt and right heart enlargement over time, but cyanosis is usually absent unless it progresses to pulmonary hypertension. Hypoplastic left heart syndrome is another critical duct-dependent lesion, where the left ventricle is underdeveloped and can't support systemic circulation. The right ventricle has to pump to both the lungs and the body through the ductus arteriosus. These babies develop heart failure and shock as the duct closes. Let's mention a few important associations. In babies with 22q11 deletion, like DeGeorge syndrome, you can see outflow tract defects such as Tetralogy of Fallot and truncus arteriosus. In Turner syndrome, watch for coarctation of the aorta and bicuspid aortic valve. And finally, a quick word on chronic stridor in infants because it sometimes overlaps with congenital cardiac causes. Laryngomalacia causes inspiratory stridor that's worse with feeding or crying. Vascular rings cause biphasic stridor that improves when the neck is extended. Airway hemangiomas can cause progressive biphasic stridor, often with skin hemangiomas in a beard-like distribution. Alright, let's wrap this up with a few key takeaways. When you see a blue baby, first decide if it's central or peripheral cyanosis. If it's central, do the hyperoxia test. If oxygen improves saturation, it's pulmonary. If not, it's cardiac. Start prostaglandin E1 if you suspect a duct-dependent lesion. Remember the classic murmurs: holosystolic at the left lower sternal border for VSD, continuous machinery murmur for PDA, and harsh systolic murmur at the left upper sternal border for tetralogy. And always link congenital heart disease with syndromes: Down syndrome with AV canal, Turner with coarctation, DeGeorge with outflow tract defects. That's congenital heart disease in a nutshell. On step 2, the key is not to memorize every anatomy detail but to recognize the physiology, who's cyanotic, who improves with oxygen, and who needs that prostaglandin drip right away.